So thank you very much. George pointed out a couple of things that I think are very important. One is lipids are part of the whole equation. So there's glucose, blood pressure, and lipids. So I'm going to change direction a little bit and talk about lipids. What we're talking about here is assessing risk in patients. And all three are important. By the way, he mentioned Steno as a trial where you reduce all three risk factors, and there's very little data on three-factor reduction. In the current issue of Diabetes Research and Clinical Practice, we have a paper looking at the US VA population of people who met 1 goal, 2 goals, or 3 goals. There's not much data on this, but people who met 3 goals over the next 5 to 10 years had very good outcomes compared to people meeting 1 goal or 2 goals. So this is added evidence for what we think is a sensible thing. Another question that Sanjay had raised with me when he asked me, to talk about lipids was about risk assessment and risk engines. And one of and I will bring it up in my talk, we rely on UKPDS, which is based on people living in England in the 1970s, which, they had not much risk anyway. Or Framingham, which is a completely white population in a suburb of Boston, totally irrelevant as well. And we have created very recently a new risk engine called Bravo based on the Accord population, which is very representative for the US, across the US population. Sanjay was asking me about how do you apply all this to an Indian population? You can't. You got to create your own. So this is a challenge for you, Arvind. Go out and create an Indian risk engine, collect data, and I think you need it because you're relying on goals that are based on completely irrelevant data to you. Every population is different, and you need to find the right kind of thing. Having said that, let me tell you what I think about the lipids and the lipid story in managing dyslipidemia and diabetes. So we look at, in blood pressure, you're measuring one thing, glucose, you're measuring one thing. The lipids are much more complex. The lipids is, you're not measuring a simple thing. We're talking about lipoproteins. This is a very complex package of proteins, surface coat of apoproteins, phospholipids. Inside is cholesterol that varies a lot. There's triglycerides. So there's a whole family of particles, chylomicrons, VLDL, IDL, HDL. And when you look at it, they're very different. You start off and you eat a fatty meal, you absorb chylomicrons, which are very large, buoyant particles. You can see them floating around. This is like cream at the top if you have chylomicronemia. And then an enzyme called lipoprotein lipase breaks it down to very low density lipoproteins, still floating on the surface. Some of these, and you keep breaking it down into smaller particles. Some of these are so-called remnant particles, which are actually very, very atherogenic. And we don't measure it. We don't measure it in routine clinical chemistry. You then get down to LDL, which I will talk about, which is the really bad one. There's on the side Lp(a), which is just coming back into measurement fashion because of PCSK9 inhibitors, but is very relevant in an Indian population because many Indians have maybe normal LDL and eating non-meat related foods, yet having atherosclerosis, and Lp(a) may be a player. And then very small HDL, high density lipoproteins, which are supposedly protective, but here too you have different types of HDL. Some are less protective than others, and this has made HDL into a very complicated substance and a very complicated target for treatment, which has actually failed in many ways, except for one treatment, which is exercise, but does it in many different ways, may not be doing it through HDL. So ApoB is the lipoprotein that's very, very important in inflammation. George pointed out that the lipids are stimulating inflammation along the vasculature, and they attract these monocytes once ApoB is within the arterial wall and brings in the monocytes, and ApoB interacts with monocytes to set up this plaque, which ultimately leads to myocardial infarction. So that's the background as to why lipids are bad, and that lipids, when we talk about lipids, it's not one single thing. The simple thing, though, is what are we doing in reducing risk? And you find that globally, people are not meeting targets. A lot of people still have high blood pressure. If you look at a simple thing like cholesterol, which is a very simplistic way of looking at lipids, it's elevated in large proportion of patients, and people continue to smoke. With LDL, I think there's very little doubt with LDL that the lower is better. And the highest, how low do we go, depends on what your other characteristics are. So you have people with coronary artery disease and diabetes, they have the highest risk, and maybe we should be bringing them to the lowest possible, almost to the level where you look at levels in people who have no CVD and no diabetes, their risk is very low despite their LDL. And the AHA and ACC a few years ago said, don't worry about measuring lipids and repeated measures. You do this heart attack risk calculator, which is based on Framingham, and you identify people at risk, and then you choose them with a statin therapy, and you can choose your statin therapy depending on whether your LDL is very high, you use a high-intensity statin, otherwise you use a low-intensity statin. If you have diabetes, you choose a high-intensity statin. And then it doesn't matter what your LDL reduction is, you just carry on with that. Now that's a very simple way of looking at it, no goals, makes life easier. But it gets back into what do we do in practice? If you have no goals, your patient doesn't know what to be taken. Same with blood pressure. We went from 130 to 140, back again to 130. And I'm going to come back to this thing about no goals. We need goals because that is what we shoot for in practice. And there's now data to support lower goals. So this is still the current AHA-ACC guideline that if you have diabetes and you have or you have a 10-year cardiovascular risk of greater than 7.5%, you choose a high-intensity statin, which means a atorvastatin or rosuvastatin in fairly high doses. For people with less severe disease without diabetes, you can choose some of the other statins. Well, I think this approach is wrong. It fails to recognize the very wide range of risk in patients. It fails to recognize that some people have recurrent events. So there's a big difference in a patient who has got a lot of risk factors and somebody who had a myocardial infarction last year is got another infarct or acute coronary syndrome this year, and you've got to do something because they could die with their next event. And some are at much higher risk than others, despite the fact that they might have the same level of LDL cholesterol or same blood pressure. You also have the problem of a lot of people out there who are intolerant of high doses of statins. I'm not going to go into great detail on this because Sundar is going to talk about statin intolerance next. I think it's a very important problem in clinical practice because of other doctors. There's a particular doctor I don't like, it's called Dr. Google. Everybody goes to Dr. Google to find out what's the side effect of their medication. And I tell people, you got backache because you're not sitting properly, and you got dementia because you didn't die of a heart attack, now you're old enough to get dementia. It's not your statin, but people don't listen. Dr. Google tells them they should not take their medication. I'm going to leave that bit to Sundar to address. But there's very good data that lower LDL is better. And I'm going to show you some very recent clinical trial data that supports this. And finally, there's some genetically mediated risk that could be overcome with a better understanding of science around some of the things that we've heard about. Another thing that we have used the term diabetes as a cardiovascular risk equivalent based on some fairly old data that show that if you have diabetes, your risk of an MI is the same as somebody without diabetes who has had a prior MI. That actually is very flawed data. It was based on 2 studies that took men, only men in their 50s, and ignored the rest of the population. So I want you to look at, this is a very nice paper in Diabetologia by Naveed Sattar from the UK, who looked at 2 other important components of risk. One is age. As you get older, your risk goes up. But in terms of diabetes, probably the duration of diabetes is a very key factor. So if you have diabetes for 10 years, you're likely to be older because you're 10 years after you got your diagnosis. So that also has an interaction over there. but your risk is much greater than if you just got diabetes and you're 35 years old, which is happening very commonly. So you need to assess, evaluate risk in a very careful manner. And I come back to the issue of risk engines. You need that, and you need that for the population that you're assessing and your patient falls into. But a lot of it, if you don't have a risk engine, is based on your clinical judgment. This is a high-risk patient. You need to treat them differently from a less high-risk population. And I'll come back to that when we talk about the new ACE guidelines, et cetera. In terms of diabetes patients whom you're seeing, clearly somebody with diabetes who's had a prior MI is at high risk, and the highest risk population you see today is a patient with heart failure and diabetes. Their risk of mortality is extremely, extremely high, and you have to intervene to do something. Now, you've seen this various forms of these regression lines based on clinical trials, and they cluster around this line. It's very tight relationship between LDL levels and cardiovascular event rates. This has been seen from 4S placebo versus if you go down to 4S, a statin treatment. Heart protection, placebo, and heart protection statin. You lower it, you lower your patient's risk. And with the statins, we couldn't really get much below 70. So 70 was put as an arbitrary cutoff, knowing that in very high-risk patients, you brought it down into the 70s, everything was okay. And this data is old, and now we have newer data that not only supports this, but takes us to a lower level. And then this was followed by, in 2014, guidelines suggesting that if you got your LDL down to below 50, your risk was even lower than that. But there was pushback from purists, clinical trialists, who said, you've never done a clinical trial with a goal of less than 70 or less than 50. This is just based on a few small number of patients, and is a false assumption. So that controversy led to this kind of problem. So I'll come back to that when we look at clinical trial data. Let's look at how should we be evaluating our patients with lipids. First of all, a fasting lipid profile is strongly recommended. And there you will find the important result, which LDL, which I've just mentioned to you. You could also look at HDL. I think HDL is important because you have a few patients who have a high cholesterol. Yeah, and their LDL may be slightly high as well, but their HDL is also high. Those people actually have very little risk. So HDL is useful in that term in evaluating your patient's risk. There's a study that's been done by NIH over many years, looking at people who live to 100 and more and their families. And there's only one thing that identifies your chance of living long, and that's a high HDL cholesterol. So I'm trying very hard, drinking red wine and things like that to get my HDL up. Another very useful test, actually ApoB, I've mentioned ApoB as a trigger. ApoB is a good test, it's a better predictor than LDL, but it's very expensive. So we do the poor man's ApoB test, which is non-HDL cholesterol. It has one other advantage. Your patient doesn't need to be fasting. I have a problem with patients who come to see me in the afternoon, and I tell them, come back to do your lipid profile fasting. They don't show up for 2 years. And then I look really bad because nowadays we get grades from the insurance companies. We look bad because we didn't do the lipids. So now I do total cholesterol and non-HDL if the patient is non-fasting. And it gives you, there are goals for that I will come to. Triglyceride can be useful. Again, you need a fasting blood sample. And I mentioned measuring lipids, ApoB, ApoA1, but we really can afford to do that. There are additional screening tests for evaluating risk. They have various little bits of uses. Coronary artery calcification, the best result you can get, the most is if you have no calcification, your risk is actually very low. Most people with diabetes have some calcification, it doesn't tell you very much. You get occasional patients whose levels are very high, score more than 300, there it is useful. So if you're very high or very low, it is useful. In between, it's not particularly useful, I think. HSCRP in most of my patients is elevated. It's probably of very little use. There are a few other tests that I don't do in practice. Their value is actually very little. So we still have this problem. We have statins, and I'm not going to talk much about statins. They have lowered the risk in a wide range of patients. Primary prevention, we started with secondary prevention, 4S study, then went to primary prevention, west of Scotland, several others. Then the very simplistic heart protection study. It doesn't matter what your cholesterol is, you take a statin and you lower your risk. Doesn't matter where it goes to, it's sort of driving this new guideline. And then a few others, including Jupiter, that took relatively low risk people and lowered their risk with rosuvastatin. But it didn't eliminate risk. And you still have some heart attack risk in many patients, particularly those with diabetes, and we call this residual risk. So this is really what you should be evaluating in your practice. Despite statin therapy, now it may be that your patient is not taking their statin appropriately, but your residual risk is a real problem. And despite the fact that you have reduced their risk, they're still having events. So what are you going to do? I'll touch on some very briefly. Fibrates, they didn't work in the Accord trial. That value is really a little doubtful, except in people who have very high triglycerides and maybe a low HDL cholesterol. Niacin, there's a large NIH trial called AIM-HIGH, no benefit at all. Bile acid sequestrants, we really don't have good outcome data. They do lower A1C by 0.5%, so I find some value there in using it in some people. What about blood pressure control and glucose control? And you heard from George, you get some benefit, but actually you still have continued risk. So I come to the two where we have new data, ezetimibe and PCSK9 inhibitors, that go beyond statin therapy, give you some benefit. So here is the data with an ezetimibe trial. Now there are some problems with this, in that this is a relatively weak drug, lowers LDL cholesterol very modestly. So it takes a long time to see a benefit. 7-year trial, so the number needed to treat is very high, and that raised a lot of questions with the FDA, et cetera. The overall result was positive, but let me see if I can, okay. In yellow here is the population with diabetes, and here is the people without diabetes. So although the result, when you put them all together, appears modest, it's because those who did not have diabetes had hardly any benefit. The benefit is seen mainly in people with diabetes, where the result is very striking. One other additional group where you have benefit with ezetimibe plus statin is in people with chronic kidney disease. There are a number of trials, not a large number, a few trials in people on dialysis with a statin showing no benefit at all in terms of preventing heart attacks. In people who are not yet on dialysis, the benefit is very modest with a statin. But if you add ezetimibe, you get additional benefits. So somebody with diabetes and diabetic nephropathy, I think using a statin alone has modest benefit. Adding in ezetimibe gives you additional benefit. And we tend to use it a lot, particularly now that ezetimibe has come down in price and is generic. What can we do beyond that? And one of the things is a better understanding of how we regulate cholesterol. So we clear cholesterol from the circulation by the LDL receptor, take it into the cell, and this LDL receptor, this cholesterol is needed within the cell, it's metabolized in the liver cells, it makes bile, but LDL receptor needs to come back out so that it can bring in more LDL particles into the cell. And this is called recycling, and it's inhibited by this PCSK9. One other thing I want to mention is the issue of familial hypercholesterolemia, which is a very common thing, very high levels of LDL, and many of these patients have either a mutation of the LDL receptor or ApoB, and now we are recognizing mutations in this protein convertase substituent kexin type 9 or PCSK9, and is associated with some people who have familial hypercholesterolemia. So this got a lot of attention a few years ago when they discovered these mutations. They also discovered what PCSK9 does, and it looked like an attractive treatment target. If this is stopping this recycling, if you block it, you'll be able to recycle the LDL receptor more efficiently. And monoclonal antibodies were developed against PCSK9. This was done very rapidly. You can then, very powerful way of reducing LDL, as I will show you. The new developments there to make small molecule tablet things affecting the mRNA of PCSK9 that will allow an oral preparation to lower LDL just the way we do currently with injections. So this was discovered only around the year 2000. Very rapidly these antibodies were developed. Human trials were started in the early 2000s, and it went from animal studies to human studies very, very quickly in 2012. And now we have clinical trial data that I will show you in a minute. So just to reiterate, hepatic LDL receptors are key in removing LDL from the circulation. And these receptors need recycling, and PCSK9 is a key player in this whole process. What was then discovered in some populations that there are genetic variants in PCSK9. So if you gain PCSK9 function, you have less LDL receptors, and you could also lose this function and have more LDL receptors if you have a different kind of mutation. And this occurs in a small proportion of the population. So what's the clinical consequences in this? So if you have the mutation that resembles familial hypercholesterolemia, and you have very high levels of LDL as a result, you have more coronary artery disease and particularly myocardial infarction. Much more interesting are the people who have mutations of the PCSK9 where you lose function. So this is not very common, unfortunately, 1% of the population, but your risk is that you're actually protected against having an MI. So this is the kind of genetic abnormality you want to have. So with that, it gave a bigger thrust to developing these antibodies. So I want to talk now about how they work, how well they work, are they safe, and what will their role be, not just in treating cholesterol, but in reducing risk in people with diabetes. So we have two preparations on the market now, evolocumab and alirocumab. I think they're very similar in terms of their mechanism of action. They're monoclonal antibodies that just knock out the PCSK9 levels very drastically. So you can see following an injection, very rapid drop in LDL cholesterol for about 2 to 3 weeks, and then the levels start going up again. So you need to give injections every 2 to 4 weeks, depending on how high your LDL cholesterol is. So here are the data with the two drugs in various doses, alirocumab 50, 100, 150, 200, and you see the reduction in LDL cholesterol. This is very often over and above statin therapy, although there are some studies in people not taking statins, particularly statin intolerant patients, but you can get anywhere up to a 60, 70% reduction in LDL cholesterol levels. In comparison, statins lower LDL by about 25, 30, maybe 35%. So this is much, much more powerful, and if you do it on top of statin therapy, you can get a tremendous lowering in LDL cholesterol. So some of these studies were started. One of them was the Odyssey long-term, and I'll show you some of the data, outcome data in a moment. Here is the LDL at the start, around 120, and the LDL came down to about 40 and was being maintained out there. The earlier studies were designed more to see safety and how effective these drugs could be. I think it was important because they're monoclonal antibodies, and then you get antibodies to these antibodies. This has happened to a few of the drugs that have to be, their development was abandoned, or you get hypersensitivity reactions. But two of them are now on the market. They'll be based on these trials. The Osler trial lowered LDL again from about 120 to 140. And early studies were not powered to look at outcomes. So each individual trial did not determine outcomes sufficiently. So meta-analyses were done, and it showed a suggestion towards lowering myocardial infarction, but we wanted outcome trials. And we now have this. So these meta-analyses are based on the oral trials, which were designed to show efficacy on LDL lowering as well as safety. So based on those, we continued to see this meta-analysis, meta-regression showing that even if you go below 70, you were able to reduce myocardial infarction, but we wanted proof with outcome data. So here are some of the data of particular types of patients. People with FH, familial hypercholesterolemia, either with alirocumab or evolocumab, baseline LDL around 150, 60% LDL reduction, and about 60% of patients are able to meet their goals. Or if you take patients with very high risk coronary artery disease, not at goal, their LDLs are above 100, you reduce them by 60%, and you can get almost 90% of people to the goal being of LDL. At that time, the goal was 70. And then you have a few patients with statin intolerance that Sundar will talk about further, their baseline LDL. These people are not on statins. These people are previously on statins already. So statin intolerant patients have LDLs of around 190, and they were able to reduce it. And depending on what their goal was based on their clinical features, about 80% of people could meet their goal. So looking beyond LDL, what else happened? So if you look at both these drugs, you look LDL, as I pointed out, lowered by about 60%. You also lowered non-HDL cholesterol. Now, one of the problems with non-HDL is a good bit of it is LDL, but you also are changing some of the other particles. ApoB is reduced by about 50%. And Lp(a), which for previously there was very little treatment, niacin lowers it a little bit, thyroid hormone a little bit. Lp(a) falls by about 26%. Triglyceride fall is very modest by about 13%, and a very small increase in HDL cholesterol. So what about safety? So these trials were done, Odyssey and Osler, generally very safe, very few serious adverse events, very rare cases of transaminases going up, just about 1% of people, not much of increase in muscle aches and pains, very few patients having a rise in CK. And one of the concerns was about neurocognitive events, loss of cognitive function, and at least in the 48 to 72 weeks, which I think is actually a very short term in relation. If you're going to get CNS dysfunction, it's going to take much, much longer. But in the short term, it was relatively modest. So the FDA felt that overall neurocognitive dysfunction was not much of a problem because it occurred in the placebo groups as well in more or less at the same kind of rate. So the drugs were approved without outcome data. And this was a problem because they hadn't yet shown a reduction in myocardial infarction, but they came in at a very high price. So insurance companies were not willing to pay for that. Another very important question that I want to address is, do these drugs cause new onset diabetes? As you know, there's been very much controversy about statins and also some animal studies and genetic studies suggesting that LDL is very important in relation to beta cell function, and you might have some abnormalities there if you lower LDL too much. In general, FH patients do not have insulin resistance, and the high intensity statins do not aggravate insulin resistance. But there's some possibility that you might have some abnormalities that might lead to this. So they looked at very carefully in this large pool of safety studies. You're at people on ezetimibe as a control, you're at placebo-controlled studies, and you look at new onset diabetes rates, and it was actually less than placebo and about the same as ezetimibe in these studies. Whether you looked at fasting glucose or HbA1c, it really didn't matter. So anyway, here is the Osler study showing small reduction in MACE, and Odyssey long-term also showing some reduction in MACE, but still not conclusive. So around 3 years ago, we had the ability to lower LDL a little bit. We were seeing some reduction in vascular events, but we wanted the definitive data. And just to reiterate the issue of risk, if you have no diabetes, this is your risk on placebo, the MACE events per year. if you give them the therapy, you had some reduction in that. In those with diabetes had the greatest risk, and you got reduction, but there was still some degree of risk. So what's new? We now have the outcome trial result data, which I will show you in a minute. These were trials designed not for safety, but event-driven outcome studies. And they support the lower goals, support the ACE guideline, which I will discuss after that. And this is, for the first time now, we have a reduction in mortality and the consequences of not treating LDL cholesterol, and the suggestion that maybe ACC and AHA need to rethink their guideline, and I understand that in November you will get a new statement from them. So let's look at this data. Here's the Fourier study with evolocumab, which came out a little while ago, where they took people whose LDL was not bad. They were on statin therapy, they had cardiovascular disease, the LDL was 90, and the goal was 70, so they're not very far away from goal, and they lowered the LDL to 30 and maintained it out for the duration of the study. And here's the primary efficacy outcome. There was a reduction of 15%, which actually seems modest, but you think about what's your control group. Your control group are people who are having aggressive statin therapy, and many of them on ezetimibe as well. So this is pretty good therapy. This was a therapy that we've been using and you are using very widely. So there is an added benefit, although it appears modest. One of the issues were, what's the rate of cardiovascular death? They were looking all at composites. They did not reduce all-cause mortality, and this was, again, somewhat disappointing. Part of it was this was a relatively short duration trial, and it may not have been adequately powered for all-cause mortality. So now we have the Odyssey trial, which has very recently been presented. I just want to go through the data in a little more detail. So these were in people over the age of 40. They had had an acute coronary syndrome 1 to 12 months prior to randomization, very often a myocardial infarction or in some cases of unstable angina. They were already on high-intensity statin at a maximum tolerated dose, either rosuvastatin 20 to 40 or atorvastatin 40 to 80. They had inadequate control of lipids in that the LDL was above 70 and non-HDL greater than 100 and ApoB greater than 80. And the primary outcome was coronary death, non-fatal MI, or fatal or non-fatal stroke, and acute unstable angina requiring hospitalization. They looked at a number of these individual components are tested in a hierarchical sequence, which means when you start off by looking at coronary death, then other events, then cardiovascular death and all-cause mortality, and then you stop when something becomes not statistically significant. So they took these patients, they were randomized to alirocumab every 2 weeks or placebo every 2 weeks following a run-in period of 2 to 16 weeks. One difference, you remember the evolocumab study. They came down to 30 and they stayed at 30 because they stayed on the same dose. For some reason, because of concern that maybe LDL, too low LDL may be bad, they had, if they took a target of 25 for people who fell below the target, they reduced the dose. So this introduced a little bit of difference between the two studies. If you were high, you came in the trial, the target was to keep your patient between 25 and 50. So some people who dropped below 25 had a reduction in dose. And that becomes obvious when you see the graphs of the LDL levels. Age were equal in both groups. 30% of people had diabetes, 65% had hypertension, there were a fair number of smokers, and 20% of people had at least myocardial infarction, the rest having unstable angina. LDL cholesterol was 87, something that most of us would find very acceptable. Non-HDL was a little higher than goal. I would like a goal of 100. HDL was 43, triglycerides were actually fairly low, and Lp(a) was slightly elevated. So 88% of patients were taking high doses of atorvastatin or rosuvastatin. The rest were taking modest doses or some other statin. And a small proportion of patients were taking ezetimibe with or without a statin. and only 1% were not taking any lipid-lowering therapy at the start of, and very often the reason for that is that they were intolerant. So this baseline LDL was 90. It came down to about 37, and then because for those who had dropped below 25, they had a reduction in dose, it went up a little bit, and at the end of the trial, the mean LDL was 53. So this is higher than what was seen in the other evolocumab trial, but there's a difference. This trial was designed to be of longer duration, so you have a better chance of evaluating events. These are very important things, as I always point out when you're making comparisons between trials. Duration of the trial and duration of treatment makes it very important. And on treatment, you could maintain 53. If you looked at intention to treat, which means some people dropped out of the treatment, the LDL was still lower at 66. So here's the overall on-treatment analysis, starting off at 93 and ending up at 53. So here's the primary endpoint. Primary MACE reduced by 15%, which was highly significant. And the main secondary endpoints, if you start looking at it in a hierarchical kind of way, all of them, or many of them had positive outcomes. Cardiovascular events reduced significantly. Death, MI, stroke reduced significantly. And this trial showed a reduction in all-cause mortality. So very good outcome from this particular trial, particularly for the first time showing with this class of drug a reduce in all-cause mortality. So they looked at a number of endpoints, subgroup analysis. What happened if you started the trial with an LDL less than 80? So 70 to 80. If you were less than 70, you couldn't enter the trial. So you had a reduction. The reduction was small, and it was not statistically significant, obviously not powered. The greatest benefit was seen in people with coronary artery disease whose baseline LDL was greater than 100. So you're talking about people whom you cannot control with a statin, and you know that they are at risk, and you want to do something more, you get a much greater benefit. And here's the reduction overall, 25% reduction, highly significant. If you further and they looked at a variety of endpoints based on and all of them keep showing that those who had a baseline LDL greater than 100 were going to get the greatest benefit. So in summary, both evolocumab and alirocumab lower LDL by more than 50%, with or without background statin therapy in a wide variety of patients. This includes patients with familial hypercholesterolemia, high-risk patients on max dose of statins whose LDL is not at goal, patients who are statin intolerant, or those who have never taken a statin or not for reasons we don't understand. There's significant benefit of these drugs in addition to guidelines, and generally they are well tolerated. There was no signal of adverse events based on LDL achieved, including patients who got their LDL down as low as 15. We don't know what will happen long term, but for the duration of these trials of 3 to 4 years, they were tolerating LDL levels of around 25. So here is, sorry, this doesn't show up very well. This is the new risk category based on the ACE guideline, which some of you may have seen. I'm on the committee that wrote these guidelines. We have just met last week to update it. There's very little new information other than the alirocumab trial. So let me just take you through this group of extreme risk patients. We define it as people who have progressive atherosclerotic cardiovascular disease, including unstable angina, and people whose LDL is less than 70. They have either established cardiovascular disease, very often they have diabetes, or stage 3 or 4 chronic kidney disease. So here again, a population that doesn't respond very well to statins. And they have premature cardiovascular disease defined as less than 55 years old in a male or less than 65 in a female. Based on these trials, both the ezetimibe trial and the PCSK9 inhibitor trials, we have recommended a goal of less than 55 for LDL cholesterol, a non-HDL cholesterol goal of less than 80, and ApoB goal of less than 70. Very high risk group are people who have not got a recurrent or recent events, and for them the LDL goal should be less than 70. This is like what the previous goals were, and a non-HDL goal of less than 100. High risk patients are basically people who have multiple risk factors. About 10 to 20% of people with diabetes, those who have stage 4 chronic kidney disease, and the goal in these people is an LDL of less than 100. And I won't go into the rest, they are very much the same. So how do we monitor therapy? I think we should reassess individual patients' lipids therapies, maybe 6 weeks after starting the therapy initiation, and then every 6 weeks till you get to a goal. While you're on the statin therapy, patients should, once they're stable, you could maybe test them once every 6 to 12 months. Particularly people stable on statins, I think you really don't need to worry about side effects once they're stable. You don't need to worry about failure, long-term failure of statins like with glycemic control. And again, an important thing in making these measurements is to detect non-compliance with therapy, which is a serious problem. About 20 to 30% of people with known coronary artery disease and diabetes are actually not taking their statins. This is based on insurance data, where the insurance company wants to pay for the statin, but the patient is not filling the prescription. So if you ask the patient, are you taking the medication, they usually will say yes, but when you show them that their LDL has jumped up, then they say yes, I had stopped taking it, I had forgotten, and so on. So we also recommend measuring liver enzymes, although the true rate of liver toxicity is extremely low with statins and is an idiosyncratic reaction that occurs very early in therapy. There used to be a lot of concern about liver abnormalities. Yes, you do get, so these drugs are working in the liver after all, and they're inducing some enzymes. A lot of that background abnormalities, I think, is related more to fatty liver in this population, unrecognized NASH or fatty liver disease. And then, occasionally we assess creatinine kinase. I really don't think it's a very useful test. If it's very high, it tells you about rhabdo, but it has really no use for people who have occasional muscle aches and pains. But Sundar will probably address this in greater detail. So the last question is a very challenging one. Is this cost effective? And it all depends on the cost of medication. So a very interesting thing has happened. These drugs came on the market with a price of about $14,000 to $15,000 per year. Yet we saw what actually appears to be a very modest benefit in terms of events. It's modest on a population level, but for the patient who's having recurrent MI, it's not very modest, it's very effective. But is it worth paying that kind of money? And this question has now, in a way been alleviated by the Odyssey outcomes, where if you treat long enough for about 4 to 5 years, you are seeing the benefit. The question is, how many people and for how long can you continue this therapy? So based on the data and pressure from lack of prescriptions and insurance questions, the price has actually been recently lowered, and there's been better uptake and more coverage from insurance. So over time, I think we will be able to address this question a lot better. Do I have some time for questions or for cases? Or
we have. We'll take the questions after the next lecture.
Okay.
Because it's relevant with the lipid. This case study can go on.
Okay. So I will stop there, and we can discuss cases later on if we need to.
Thank you very much, sir. It was a very lucid.